Good morning. For today's Clinical Explainer on Teaching Rounds, we're going to be meticulously evaluating acute cholecystitis. We'll be looking really closely at both the calculus form, the one driven by an impacted stone, and that much more insidious acalculous disease we so frequently encounter in our critically ill patients. My goal today isn't just to identify the disease. I want us to spend our time unpacking the exact mechanisms at play here. We'll examine exactly why the gallbladder wall fails, why timing dictates our surgical options, and why certain laboratory thresholds demand that we immediately shift our focus to the common bile duct. Let's get started. Our case presentation today is going to unfold across 4 distinct acts. First, the admission presentation. Second, a pathophysiology deep dive. Third, our clinical assessment and management. And finally, we'll wrap up with some contrast cases and clinical pearls. So, Act 1, the admission presentation and evaluating our patient Marcus. Let's head to the bedside. Marcus is a 58-year-old male with a history of type 2 diabetes and a body mass index of 34. He presents to us with 16 hours of constant right upper quadrant pain. His history is incredibly classic. The pain began in the epigastrium within about an hour of a heavy meal, then it eventually settled right beneath the right costal margin, boring directly through to his right scapula. And here's the key, it never broke. Associated symptoms include 4 episodes of vomiting, some subjective chills, and anorexia. He also describes having 2 or 3 shorter, self-limited attacks earlier this year, always after rich meals, which really served as his warning phase. On our initial evaluation, his temperature is 38.3 degrees Celsius and his heart rate is 104 beats per minute. His sclera are not icteric. His initial lab work shows a white count of 15,800 with a left shift, an elevated C-reactive protein, a total bilirubin of 1.6, an alkaline phosphatase of 142, and transaminases of 61 and 74. His lipase is normal. Now, the absolutely crucial clinical turning point in evaluating Marcus's presentation is understanding exactly why this is not simple biliary colic. Biliary colic happens when a stone transiently blocks the cystic duct and then falls back, which allows the gallbladder to decompress. The defining feature of colic is that the pain invariably breaks, typically within about 6 hours. Marcus's pain, however, has been unrelenting for 16 hours. This tells us the stone has wedged in the duct and stayed there, converting a transient functional block into a permanent mechanical seal. Unrelenting pain past 6 hours, combined with his fever of 38.3 degrees Celsius and an elevated white count of 15,800, that definitively signals that Marcus has crossed the threshold from simple colic right into acute cholecystitis. On physical exam, Marcus exhibits focal right upper quadrant tenderness with voluntary guarding, but no rebound or rigidity. He also demonstrates a positive Murphy sign. It's really worth pausing here to review the precise mechanics of this exam, because honestly, it's often misinterpreted. To elicit a true Murphy sign, you don't just poke. You place your fingers firmly under the right costal margin at the mid-clavicular line, press in, and hold completely still. Then, you ask the patient to take a slow, deep breath. You aren't pushing up into the gallbladder. Rather, the patient's descending diaphragm is driving the inflamed gallbladder down onto your stationary hand. The definitive positive finding isn't merely that it hurts, it's that the patient's breath abruptly catches and stops due to the sudden pain. Inspiratory arrest is the sign, and Marcus exhibited exactly that. Moving on to Act 2, the pathophysiology deep dive, taking us beyond the cystic duct. Let's look at things at the cellular level. In Marcus's case, a stone has wedged tightly in the neck or the cystic duct, creating a sealed, blind pouch. Now, because liver to duodenum flow remains entirely untouched, he isn't clinically jaundiced and his bilirubin sits at a near normal 1.6. But behind that seal, a lethal cascade is starting. The gallbladder mucosa continues to secrete mucus and fluid into a space that literally cannot drain. So intraluminal pressure aggressively climbs, distending the wall. As that pressure rises, it compresses the mural vessels, choking off venous and lymphatic drainage, and eventually the arterial supply. This mucosal ischemia triggers the release of phospholipase and prostaglandins, driving massive cellular edema. It becomes a vicious cycle dictated entirely by time. Obstruction causes pressure, pressure causes ischemic injury, and the resulting inflammatory injury causes even more pressure. Now, I want to strongly correct a very common misconception here. Infection is not the primary driver of acute cholecystitis. In fact, 50% of these gallbladders are entirely sterile at the onset of symptoms. This is fundamentally a pressure and ischemia disease first. When infection does occur in the other 50% of cases, the usual suspects are Escherichia coli or Klebsiella, straight from the gut. But here's the thing, these bacteria are passengers, not drivers. They arrive and proliferate only after the gallbladder wall has already been damaged by the rising pressure and ischemia. This distinction is absolutely critical because it explains exactly why simply administering antibiotics will never cure an obstructed cystic duct. Left alone, this dying wall follows a very predictable natural history. Edema gives way to severe congestion, arterial failure leads directly to gangrene, and the sealed pouch may fill with pus, creating an empymia. Ultimately, in roughly 10% of acute cases, the wall will perforate. Time, not bacterial virulence, is what drives this sequence. I really want to pause here for impact so we fully absorb this reality. Relieving the mechanical obstruction is our only true exit strategy, because time is the real enemy. That brings us to Act 3, Assessment and Management, looking at imaging and our plan on the ward. When evaluating the right upper quadrant ultrasound, we have to discipline ourselves to read past the stones. Finding stones alone doesn't confirm an inflammation diagnosis. Plenty of people have completely asymptomatic gallstones. We're looking for specific markers of mural edema and inflammation. A normal gallbladder wall is 3 millimeters or less. We look for a wall measuring over 4 millimeters. For context, Marcus's wall measures 5 millimeters. We also look for a rim of pericholecystic fluid tracking around the outside of the gallbladder, which Marcus has. We assess for a sonographic Murphy sign, where the maximum point of tenderness is reproduced directly beneath the ultrasound probe. And finally, we look for an impacted stone wedged at the neck that's no longer mobile. If ultrasound were technically inconclusive, maybe due to body habitus or bowel gas, we might order a computer tomography scan or a hepatobiliary or HADA scan. A HADA scan is 80 to 90% sensitive, testing whether the cystic duct is functionally open. For Marcus, however, the ultrasound is definitive. We formalize our diagnosis using the Tokyo guidelines. These criteria are divided into 3 parts. Part A requires local signs of inflammation, like a Murphy sign or right upper quadrant pain. Marcus has a definitively positive Murphy sign. Part B requires systemic signs of inflammation, such as fever, a raised C-reactive protein, or a raised white cell count. Marcus has a temperature of 38.3 degrees Celsius and a white count of 15,800. And Part C requires imaging findings characteristic of acute cholecystitis. Marcus has a 5 millimeter wall and pericholecystatic fluid. Meeting one criterion from A and one from B makes it a suspected case. Adding C makes it a definite diagnosis. Marcus easily meets all 3. Furthermore, because he's an otherwise healthy patient without any cardiovascular, neurologic, or other organ dysfunction, we classify him as having grade 1 or mild severity. For his initial ward management, our plan is very deliberate. First, we place him strictly nothing by mouth. This is physiological source control. Every time a patient eats a meal, the duodenum releases cholecystokinin, which signals the gallbladder to violently contract against a mechanically blocked duct. That just worsens the ischemia and the pain. Second, we provide aggressive IV fluids to correct the volume depletion from his vomiting. For analgesia, non-steroidal anti-inflammatory drugs are our preferred choice over opiates. NSAIDs are highly effective for biliary pain and, crucially, unlike opiates, they do not raise sphincter of Oddi pressure. Finally, we begin empiric antibiotics. For a grade 1 patient like Marcus, ceftriaxone plus metronidazole provides excellent coverage for gut flora and anaerobes. If he were sicker, we might escalate to piperacillin-tazobactam. But remember our earlier discussion, these antibiotics are preparation for surgery, not a definitive cure. The definitive plan here is a laparoscopic cholecystectomy, and we're heavily constrained by a strict 72-hour window. It's absolutely vital to understand that this 72-hour clock begins at symptom onset, not at the time of hospital admission. Marcus has had symptoms for 16 hours, so we're well inside the early window. Operating early is preferred because the inflammation is still primarily edematous, meaning the surgical tissue planes will still cleanly separate. Delaying surgery allows that edema to organize into dense fibrosis, which dramatically increases surgical difficulty and the risk of a bile duct injury. Now, for patients who are simply too sick or unstable to tolerate an operation, we bypass surgery entirely in the acute phase and place a percutaneous cholecystostomy tube through the skin and liver bed to drain the pressure. That allows for an interval surgery weeks later once they recover. Marcus, however, is stable and ready for the operating room. And he doesn't need an endoscopy or ERCP because his liver panel is largely bland. Let's talk about some key numbers for a second. 500. I want to begin our diagnostic handoffs by focusing right on this number. An AST or ALT above 500 units per liter means you must immediately stop your current line of thinking and look directly at the common bile duct. Simple gallbladder inflammation does not cause transaminitis of this magnitude. 4. A total bilirubin above 4 milligrams per deciliter points sharply away from simple, uncomplicated cholecystitis. Remember, a stone in the cystic duct leaves the main bile highway open. A bilirubin climbing above 4 strongly suggests cheiliticholithiasis, a stone that has actually escaped the gallbladder and is now obstructing the common bile duct. 1,000. An amylase level above 1,000 units per liter is our final threshold. This indicates that a stone has migrated entirely through the biliary tree and is now obstructing the pancreatic duct as well. If you see 500, 4, or 1,000, the clinical problem is simply no longer confined to the gallbladder. And that brings us to Act 4, contrast cases and pearls, specifically the acalculous trap. Let's head over to the surgical intensive care unit and consider this contrast case. We have a 68-year-old woman, currently on ICU day 10. She's mechanically ventilated following a motor vehicle crash. She's been receiving total parenteral nutrition and a continuous fentanyl infusion for 10 days. Today, she spikes a new fever, and her white count jumps to 19,000. A bedside ultrasound reveals a thick-walled, massively distended gallbladder, but 0 stones are present. This is acute acalculous cholecystitis. Her illness is being driven by 2 immense physiological forces. First, profound bile stasis. Because she has no food entering her duodenum, there's no cholecystokinin signal telling the gallbladder to empty. The bile just sits there, concentrating into toxic, thick sludge. Furthermore, that constant opiate infusion tightly clamps the sphincter of Oddi, preventing any forward flow. The second force is ischemia. Her initial trauma, shock state, and exposure to vasopressors chronically underperfuse the mural arteries feeding her gallbladder. This variant is terrifyingly easy to miss. Why? Well, because the classic physical exam is entirely useless here. A heavily sedated, intubated patient can't report pain, meaning a Murphy sign is impossible to elicit. Her new fever is almost always blamed on something else first, like ventilator-associated pneumonia, a central line infection, or the surgical wound itself. The gallbladder is at the very bottom of the differential. And tragically, when an ultrasound is finally ordered, the absence of stones provides a false sense of reassurance, even though stones are absent by definition in acalculous disease. Because her gallbladder is already ischemic from shock, this disease progresses to transmural gangrene far faster than calculous disease. The vital first step for this fragile patient isn't the operating room, it's immediate decompression via a percutaneous drain. Briefly, we also need to recognize emphysematous cholecystitis, which is another severe complication. This occurs when gas-forming organisms, classically Clostridium species, proliferate and literally produce air within the gallbladder wall. It most frequently strikes older diabetic males, and it's often acalculous in nature. Ultrasound can easily miss this gas. It's diagnosed definitively via computed tomography and represents an absolute surgical emergency. Finally, remember that perforation occurs in roughly 10% of all acute cases. This perforation can be contained by the omentum into a pericholecystic abscess, or it can rupture freely into the peritoneum, causing an overwhelming bile peritonitis. Delay is the sole driver of these devastating outcomes. To distill everything we've discussed today, here are 6 rapid-fire clinical traps worth committing to memory. Number 1, normal labs never exclude the disease. An open bile duct means a normal liver panel, and older patients often fail to mount a white count. Number 2, stones alone are not cholecystitis. You absolutely must read past the stones to find the thick wall and fluid. Number 3, antibiotics are not source control. They do not relieve a mechanical obstruction. Number 4, always think acalculous disease for the unexplained ICU fever. Number 5, those thresholds of 500 for transaminases, 4 for bilirubin, and 1,000 for amylase send you immediately looking for a ductal stone. And number 6, a deceptively soft abdominal exam in a sick older patient can actually mean the wall has already died and progressed to gangrene, numbing the local inflammatory response. I'll leave you with this final, provocative thought to consider on rounds today. If finding stones doesn't actually confirm the disease, and having perfectly normal lab work doesn't exclude it, are we spending too much clinical energy focusing on the wrong diagnostic alarms, especially when the 72-hour clock is our real enemy? Thank you for your time on this explainer.